Yeah, so we will shift now from chronic stable angina and ischemia to patients presented with the ACS. And yesterday we presented the new guidelines for ACS management. So after doing, for example, PCI or primary PCI for ischemic patients, what is the further management or the post-acute phase that should be done? This is my disclosure. We have to know that the long-term treatment starts from cardiac rehabilitation, lifestyle modification, as I mentioned now, pharmacological treatment, antithrombotic treatment, lipid lowering therapy, beta blockers, nitrates, RAS inhibitors, medications for diabetes, PPI, vaccination, anti-inflammatory drugs. All these big lists should be considered when you are discharging your patients after development of acute coronary syndrome to see what's further management that we need. So the treatment goal is to support healthy lifestyle, continue optimal pharmacological and cardioprotective treatment, reach and sustain risk factor treatment. So we need to advise our patients, stop smoking, eat healthy diet, regular exercise, healthy weight, psychological managements. Then look for the bleeding risk, ischemic risk, to consider which antithrombotic strategy is needed, the lipid lowering therapy to achieve the target LDL less than 55 milligram per deciliter, and annual influenza vaccination, drugs adherence is very important, and keep eyes on the parameters, the numbers, blood pressure systolic less than 130/80, LDL less than 55, hemoglobin A1C less than 7%. So the guidelines are very clear. Class 1A is multidisciplinary exercise-based cardiac rehabilitation is recommended. Class 1B, ACS patients should adopt a healthy lifestyle, stop smoking, a healthy diet, alcohol restriction, regular aerobic exercise, reduce sedentary time. Class 2A, to use all measures that can help in stopping smoking. And now we have many drugs like varenicline or bupropion or in combination, which are considered a class 2A recommendation. Regarding the anti-platelet strategy, we know that after doing PCI, all patients should be maintained for 1 year with P2Y12 inhibitors, prasugrel or ticagrelor, in addition to aspirin. If they are not available or contraindicated or not tolerated, then you have to shift to clopidogrel, and then monotherapy with aspirin, a class 1 recommendation. And we know recently, according to the evidence from many studies in the last 5 years, to shorten the duration of antiplatelets. But you have to consider every patient's bleeding risk, the ischemic risk, before considering the abbreviated DAPT strategy in high bleeding risk patients, just 1 month for DAPT, dropping aspirin after 1 month, and then to continue with the P2Y12 inhibitors or aspirin monotherapy. But other studies which are considered non-inferior in the outcome use the short DAPT for 3 months or 6 months. And those, of course, should be considered in high bleeding risk and low ischemic risk. The de-escalation from potent P2Y12 inhibitors to less potent P2Y12 inhibitors, I mean from prasugrel or ticagrelor to clopidogrel, not before first month. So don't de-escalate before the first month to avoid the risk for stent thrombosis, and de-escalation can be considered according to this slide. We can see that the default strategy is to continue P2Y12 inhibitors and aspirin up to 1 year. The long-term DAPT is considered class 2A or 2B according to the risk. If we are dealing in a patient with a high ischemic risk, you can extend for more than 12 months as long as he has a low bleeding risk, and this is class 2A recommendation. And if he has a moderate ischemic risk without bleeding risk, you can continue beyond 12 months, and this is class 2B recommendation, using rivaroxaban 2.5 milligram PID in addition to clopidogrel, or using DAPT therapy. P2Y12 inhibitor monotherapy instead of aspirin is considered a class 2B recommendation. Lipid-lowering therapy post-acute phase is very important to achieve the target LDL. So look for the patients he is naive for statin or not. So from the start, initiate a high intensity or high potent statin therapy to achieve the target LDL class 1 recommendation, and adding ezetimibe or combination therapy is class 2B recommendation. If the patient's on statin and still LDL not at the target, then combination therapy can be started. Patients who are on a high tolerated dose of statin with LDL still above 55 milligram, combination and then adding PCSK9 is very important to achieve the target LDL. And we have the evidence from important studies which use the combination like IMPROVE trial compared the simvastatin plus ezetimibe in patients with post-ACS. And in addition to the reduction of LDL by 24%, we can appreciate the significant reduction in the primary endpoint, cardiovascular death MI, unstable angina require rehospitalization, and coronary revascularization. Cardiovascular death, non-fatal MI, non-fatal stroke, also decreased significantly. Number needed to treat was 56. In addition to the use of PCSK9, also in patients with recent acute coronary syndrome, the use of aliricumab compared with statin only was associated with a significant reduction in the endpoints like coronary artery disease death, non-fatal MI, fatal, non-fatal ischemic stroke, unstable angina require hospitalization. And recently also we have some studies which demonstrated the benefit of PCSK9 inhibition in ACS, like Pacman acute MI study, which compared the adding aliricumab in addition to high-dose statin compared with statin only, and you can appreciate the significant reduction in the percent atheroma volume as well as the fibrous cap thickness, and the evolocumab in the other studies also demonstrated the same benefit. So the recommendation in the recent guidelines that high-dose statin therapy class 1A recommendation, if the target is LDL less than 55 milligram per deciliter, class 1A recommendation. Add ezetimibe if the target is not reached within 4 to 6 weeks, and if still the LDL is not at the target, add PCSK9, and this is class 1A recommendation. Also, in patients with recurrent atherothrombotic event within 2 years of the first ACS, you can add you can recommend LDL to be less than 40 milligram per deciliter, and this is class 2B recommendation. High-dose statin plus ezetimibe during the index hospitalization from the start is a class 2B recommendation. What about beta blockers? Beta blockers are recommended in ACS patients with ejection fraction less than 40%, regardless of the heart failure symptoms. A routine beta blocker for all ACS patients, regardless of the ejection fraction, is considered a class 2A recommendation. What about RAS inhibitors? In patients with ACS, heart failure symptoms, ejection fraction less than 40%, diabetic patients and or CKD, it's class 1A recommendation. MRA in ACS patients with an ejection fraction less than 40% and heart failure or diabetes, also class 1A recommendation. Routine ACE inhibitor, irrespective of the ejection fraction, is considered a class 2A recommendation. And the poly pill, according to some recent studies like Acute trial, should be considered as an option to improve adherence and outcome in secondary prevention, and this is class 2A recommendation. And the diabetes guidelines, which was published in the last EC meeting, recommended IMBA, CANA, or DABA SGLT2 inhibitors in patients with type 2 diabetes and the cardiovascular disease, or at very high cardiovascular risk to reduce events, class 1A recommendation. And liraglutide, the semaglutide are recommended in patients with type 2 diabetes, cardiovascular disease, very high-risk patients to reduce cardiovascular events, GLP-1 agonist, which is class 1A recommendation. And imaging is considered important to repeat the re-evaluation after 6-12 weeks class 1C recommendation in patients who were subjected to revascularization, to assess the need for sudden cardiac death primary prevention and the need for ICD, cardiac MRI, also a class 2A recommendation, vaccination class 1A, anti-inflammatory drugs, colchicine 0.5 milligram once daily, it's class 2B recommendation if recurrent cardiovascular disease events occur during the optimal medical treatment. And this is the outcome from the Acute trial and the use of polypill. So it's class 2A to consider to use polypill in those patients. The information should be clear during hospitalization for the patients to be sure that these patients will undergo an optimal secondary prevention starting from lifestyle modifications and the proper medical treatment to prevent further atherothrombotic events. Thank you for your attention.